Okay. Can you please? Yeah. You can just open the page. Okay. Thank you. I welcome. My name is Goldie Mishra. I lead the Logic Ultrasound business for GE Healthcare South Asia. And on this great occasion of World Liver Day, I take this pleasure to welcome all the delegates for this special webinar. And I'm happy to share we have three eminent guest faculties who are going to talk about their experience, and they are the experts in the industry in the field of liver health. We will have the sessions one by one, and subsequently at the end of the sessions, we will also have Q&A round. I would request all the delegates to please share their questions in chat box so that we can address those questions at the end of the sessions. So before I move on, I just would like to welcome our first faculty. Can I just pull the page, please? Yes. Move on to the second slide.
Yes.
So I would like to first invite Dr. Riju Mathews. Dr. Riju is a chief radiologist at Scans in Kerala, and he's an honorary treasurer at IRA. He's the Mr. Safety Ambassador was awarded at AOCSR in 2023-2025. And he has been also awarded with IRA National President's Appreciation Award in 2018 to 2023. Dr. Riju has done extensive work around chronic liver disease, and he has certain publications also to his accolade. One of them is the prevalence of chronic liver disease based on ultrasound shear wave elastography. And he also has a publication in magnetic resonance imaging safety in Asia Oceanic. So, without taking much time, I would like to invite Dr. Riju Matthews to please share his welcome address to the entire delegates. Over to you, Dr. Riju, sir.
Thank you, Goldie. And once again, World Liver Day wishes to each and everyone who has joined today. Let me share my screen. Is my screen visible?
Yes, sir, we can see.
Right. So the theme for this World Liver Day 2025 is actually food is medicine. And this is something the Hippocrates has told years ago, centuries ago, that our food should be our medicine and our medicine should be our food. But having come all this way, we have currently a major epidemic that is that the country has to face, that the fatty liver, that's India's new epidemic, not only that of India, of the majority of the countries in the world, fatty liver. The prevalence of fatty liver is nearly 33%. And there, initially, it was started with the terminologies of non-alcoholic fatty liver disease and all. Now, it is now culminating itself into a metabolic dysfunction associated steatotic liver disease, where there are several factors, the genetic factors, where the environmental factors are the predominant ones. I won't go into the details of all these things because I'm sure that Dr. Rahul Sachdev will go into the details of the metabolic dysfunction associated fatty liver disease and its pathophysiology. But one thing is sure, the non-alcoholic fatty liver disease, a term that is we were using earlier, may become an obsolete one, and we will be now focusing more on metabolic dysfunction associated steatotic liver disease or fatty liver disease, MASLD. And these are the different classifications that are coming in where the environmental factors play a significant. There is one thing that we need to understand, there is a considerable overlap between the so-called non-alcoholic fatty liver disease and the persons who consume alcohol also. So there is a lot of change in definitions happening, but there is a metabolic dysfunction that is the basic problem for any fatty liver that you come across. And as a country, India has been progressing from a developing nation to a developed nation. We have a large incident prevalence of non-communicable diseases. We do have a double burden of communicable diseases as well as deaths due to malnutrition, childbirth related issues, infant mortality, etc. But if you look at the south and west of our country, you will see the mortality has gone up basically due to coronary cardiovascular diseases, and it is there in the urban and metro areas of all over the country. So the approach towards a non-communicable disease with the current definition of clinical parameters and biochemical parameters, like the dyslipidemia with blood tests and clinical assessment, is it enough? This is a fundamental question that each one of us has to ask, because we have not been able to manage it, quantify it, and to address the metabolic syndrome, address all the non-communicable diseases in an effective way with the approach that we currently being followed, which is highly based on clinical parameters and biochemical parameters. And that is why we launched this Project Kavach, and GE is a technology partner in that. The Project Kavach, where the preventive radiology healthcare has been brought in. The radiology biomarkers can play a significant role in stratifying the high-risk group of non-communicable diseases. And it is for that, we need to give more emphasis to the concept of health span, which is disease-free lifespan. And if disease-free lifespan has to become a reality, apart from the interplay of genes, environment, and lifestyles, the diseases has to be early manifestation of diseases has to be detected with screening and early detection and downgrading of the risk factors. This is the fundamental point that we want to make through the preventive radiology. So the preventive radiology was initiated 4 years ago. This is an Indian contribution. The Indian radiologists have contributed to this. And Apart from this diagnostic and interventional radiology, preventive radiology is a new branch in clinical radiology where we are trying to stratify the risk of high risk group in non-communicable diseases, and so that the downgrading of the risk and early detection of non-communicable diseases are possible. Thereby, a different approach to non-communicable diseases is made possible. The radiologists have been telling about fatty liver for last 30 years or 35 years, ever since ultrasound was widely practiced. And it has now become, it was initially considered now a biomarker for chronic liver disease, but now we need to think in terms of it's a biomarker for cardiometabolic syndromes and even for cancers. So quantifying that liver fat is very, very important from the practical point of view. So the definition of the metabolic syndrome in terms of atherogenic dyslipidemia, hypertension, obesity, or of waist circumference being measured, and the type 2 diabetes and all, it's only giving you a general general angle towards the issue. But you need to understand that it has got larger dimensions in terms of endothelial dysfunction. This metabolic dysfunction associated steatotic liver disease has a larger dimension in terms of inflammation, in terms of insulin resistance, in terms of gut microbiota dysfunction, and in terms of endothelial dysfunction. So it's time for us to address the early biomarkers with the help of radiology in this. And it is also important to look for the endothelial dysfunction, cardiovascular, premature vascular aging, and heart failure signs, and ischemic coronary artery disease screening, etc. Because maybe 5 to 10% of fatty liver patients may go for chronic liver disease, cirrhosis, and hepatocellular carcinoma, etc. But 60% of them will develop cardiovascular diseases, and the cause of death, mortality, may be due to the cardiovascular disease. So it's high time for us to integrate the screening process. So we have radiology tools in terms of its ultrasound, color Doppler, and even in CT and MR, look for the intima media thickness, plaques characterization, reactive hyperemia on Doppler, etc., which can give, this is a CT coronary angiogram that can characterize the vulnerable plaques, that do the calcium scoring, and help us to evaluate and help us to quantify the high risk group that requires medical interventions or or aggressive lifestyle modifications. So this is a scientific statement from the American Heart Association that has come in 2022, connecting the non-alcoholic fatty liver disease and cardiovascular risk. If you look at their NAFLD is very common, but one thing that they mention, most patients with NAFLD are undiagnosed. And the measurements of SGOT, SGPT are not useful for diagnosing NAFLD and NASH because of poor sensitivity and specificity. AST and ALT levels can be normal even among patients with NASH. So it is high time that the dependence on clinical parameters, on biochemical parameters has to be, we have to pivot radiology biomarkers and radiology tests as a screening tool for effective stratification of the high risk group. And it is essential to really connect them to the risk stratification for cardiovascular disease screening. And NAFLD occurs in association with insulin resistance, with or without diabetes, obesity, especially visceral adiposity, metabolic syndrome, etc. So it's high time for us to look into, explore the radiology and imaging biomarkers, and using the radiology test to look for the biomarkers for metabolic dysfunction, like visceral fat quantification can help us to characterize the further risk of these individuals. So, I'm sure Dr. Rahul will cover how the liver fat quantification. Liver fat quantification. The fatty liver is a radiology biomarker for not only for liver disease but also for all non-communicable diseases, and with a heavily biased more towards the coronary vascular disease. So it is high time for quantify the fat, and thereby making this individual aware that he is at a high risk, even though he is asymptomatic, and can help him reduce or downgrade the risk. So this is the concept, and we have got enough and more tools to look for the fat in various organs. the subcutaneous abdominal fat. There is a ratio between the subcutaneous fat with visceral fat, which can be measured with ultrasound, which can be measured with low-dose CT, which can be measured with MRI, and fat around the organs, and also imaging biomarkers for insulin resistance in terms of sarcopenia assessment. And also one of the major advantages that imaging offers is the assessment of the target organ injury or the target organ. If it is case of liver, if it is case of heart, we can do a structural and functional assessment of that organ, and thereby making that individual more aware and their entire healthcare system who's treating that to tread cautiously and to take effective interventions and lifestyle modifications. So it is possible for us to assess the target organ injury. So a test like ultrasound, a test like CT, a test like MRI has got the capability to look for the quantification of liver fat, can assess the liver tissue stiffness, can assess the structural evaluation of the liver or heart for early chronic disease or early heart disease, and also the functional assessment can be done with Dopplers and other tests also. So radiology biomarkers should become the fulcrum objective first-line filters for high-risk screens to triage for further with the intention of downgrading of risk to increase health span, and also for early detection to increase health span. So it's time, my dear friends, to transform your practice to comprehensive evaluations, comprehensive scans from the routine USG abdomens that you are doing. Talk to your patient, quantify their liver fat, quantify the liver tissue stiffness value, do a target organ structural and functional assessment with color Doppler, with high resolution ultrasound, and look for the early biomarkers of chronic liver disease, and risk stratify, do the visceral fat adiposity and other epicardial fat assessment or other markers for cardiometabolic syndromes and other NCDs, and thereby give a quantitative assessment or a high risk stratification for this particular individual for the non-communicable diseases. And that's a new approach which with radiology tests as a pivotal, playing a pivotal role. And that is how we need to go have a different approach towards a non-communicable disease burden this country is facing currently. And it cannot be managed with the current approach of clinical and biochemical approaches alone. We need to integrate the radiology tests and the radiology biomarkers for effective risk stratification and for effective interventions. So with this setting in for this background for radiology tests to play a much more important role on this World Liver Day, I conclude my session and once again wish all the delegates who attended the World Liver Day message. The food is the medicine, but it is essential for us to create the awareness for this individual and the community that they are at a high risk when they are in an asymptomatic stage. And that is how the radiology biomarkers and the radiology imaging tests can play a significant and important pivotal role. Thank you very much.
Thank you, Dr. Riju. In fact, that was quite insightful from your talk. Thank you for sharing those insights. In fact, if I had to capture a few points which were really exciting, was the new term. When we talk about today, we have been talking earlier, we were talking about NAFLD. Now we are talking about a new term, MASLD. You also highlighted a point of that there is a difference between lifespan and health span, and how to integrate radiology indicators and radiology testing and imaging to bring, and why it is critical to quantify fat quantification in liver. So that's really insightful, and thanks for sharing that exciting presentation. And I would now move on to the next eminent faculty here, Dr. Harsh Mahajan, sir. He's a founder and chief radiologist at Mahajan Imaging, New Delhi, and he's a Padam Shri awardee as well. Also, sir is a chairman at Department of Nuclear Medicine and Pets at Shri Gangaram Hospital. He's also chairman of Center for Advanced Research in Imaging, Neurosciences and Genomics. Also chairman of Carpal AI, which is an AI-driven company. Sir, as I mentioned, his awards of Padam Shri he was awarded Padam Shri in 2002, and he's also former honorary radiologist to the President of India. Thank you, sir, for being part of this, and I would like to invite you to please share your keynote address on this World Liver Day, sir.
Thank you very much, Goldie, and Welcome to all those who have joined. I must congratulate Riju for having been the initiator of preventive radiology as a branch of radiology through initiative of IRIA. And I think this makes radiology and radiologists stronger, and also brings home the message that radiology imaging is playing a very, very important part in disease prevention, in disease prediction, and in picking up disease early so that we can take enough measures so that it doesn't become a problem later on in life. Longevity and health span rather than lifespan have become common terms now. And apart from blood tests and other things, I think radiology is playing a very increasing role. Now, I would congratulate GE on this initiative on World Liver Day, where I think across the world there are these kind of seminars, these kind of webinars, these kind of initiatives having been taken to actually educate and inform not only the medical fraternity but also society at large as to why it is important to get your ultrasound done, to get your blood test done, if you want to live a healthy life. Liver, as we all know, provides a very easy and a very important window to health of an individual. Riju has shown very nicely that liver health actually affects everything. And if there is fatty change in the liver, if there's steatohepatitis, then it also means that, like he said, 60% of these people will go on to have some cardiovascular ailment, heart disease, stroke, colon cancer is also been shown to be common with this. Obesity, diabetes, hyperlipidemias, all of them affect our liver, and it's up to us to take care of our own problems. Now, coming to liver specifically, about 34% of the global population, especially in the West, we have figures, it's 34% have fatty liver disease, or let me say liver fat above the 6%, which is considered to be normal. So fatty liver in about 34%, and then it goes on in about 10% to steatohepatitis, and then further to fibrosis, and then ultimately in those who don't take care to cirrhosis. Now, in our country, and we have figures for Delhi, there was a study conducted by AIMS in Delhi where it's alarming to know that 65% of those living in urban Delhi have fatty liver. And the number is not so less for rural Delhi. It's 61% of those in rural Delhi have fatty liver. It's a very alarming statistic, and this was based on ultrasound examination. Another alarming statistic is that in schools, obese children, 64% had fatty liver, whereas in those who did not have obesity, their weight was within limits, it was only 12%. So there is a cause and effect relationship we find, and if children are going to have fatty liver, then they have a much larger lifespan, and the chance for them to develop steatohepatitis leading on to fibrosis and cirrhosis is much larger. We reviewed our own literature, and this is under publication. Last 6 months, we looked at those under 45 years of age, and we found that 34% of our patients had fatty liver. And so, those in the younger age group in our city are equal to those spanning the entire lifespan in the West. So this is really a disease which has become, as Riju put it, an epidemic. Now, ultrasound 40 years ago, nearly to this day, we got an ultrasound in PGI Chandigarh, where I was a postgraduate student at that time. I joined in 84, there was no ultrasound. In 85, we got it. And that's when we started looking at the liver. Initially, of course, for liver abscesses, which used to be very prevalent, for obstructive jaundice, gallstones, and all of that. But slowly over time, one realized, recognized fatty liver disease, and then grade 1, grade 2, grade 3 fatty liver, which we did with eyeballing and still continue to do with eyeballing. But we know my grade 1 may be your grade 2, and my grade 2 may be something else. So it was all very subjective. It was operator dependent. And then came, the FibroScan machine, which actually came in the around 2008, 2009. Gastroenterologists started using it, and this is the maximally studied, machine. And even though it's a blind machine, the numbers appear to be quite consistent with liver biopsy. This came into its own, and then we were approached, I think it was in the year 2011, if I'm not mistaken, came a company which actually came in with an ultrasound machine where you could see the images and also do fibrosis quantification using shear wave elastography. This company was called Supersonic, and we actually had that machine in our center for a few months. But the image quality of routine ultrasound was not very good, and hence we didn't get it. Of course, it was a machine which cost nearly 1 crore rupees, and so because we could not use it for day-to-day imaging, we actually did not buy that machine. It was in 2012 that GE actually for the first time came in with their E9, Logic E9, and we were the first center in the country which got this machine where we could do excellent image quality, routine imaging of all body parts, and in addition, it was capable of doing shear wave elastography. We were able to do something similar to the FibroScan machine that was available. The advantage, as I see it, has been that here you could actually look at the area where you were placing your ROI in distinction to the FibroScan machine, which still is used by gastroenterologists, but that's a blind measurement. So, and here we could see when we started using the E9 that if you included even a small blood vessel in your area of interest, the reading would get skewed. So that's where we developed huge confidence in this machine, and there were enough studies available which showed that it matched very, very well with not only the FibroScan, but with MR elastography as well as with biopsy. So this now, over the last 12 years, has become accepted across the globe. I think hundreds and thousands of these machines have been installed, and it's then came FibroScan with CAP score, which was about 4 years ago, if I'm not mistaken. And this then became capable of doing liver fat quantification, which till that time we were doing using PDFF sequences on MRI and using MR elastography for fibrosis, which we've been doing in our centers for the last about 5-6 years. But it's a little cumbersome to do MR elastography on as compared to doing fibrosis estimation on ultrasound. And so ultrasound came into its own, and with the availability of what GE calls UGAP, we are able to do quantification very well. And why is quantification important? One, it is much more objective as compared to eyeballing, which is very subjective between grade 1, 2, and 3. Second, it is very important to have quantification, a percentage, a number, because to see change over time, suppose a patient comes in and we quantify it, and we know grade 1 fatty liver disease is between 6 and 34%. So suppose I say grade 1 fatty change, and he does everything, treatment, lifestyle change, corrects his hyperlipidemia, and suppose it comes from 30 to 20% with all he's done, we will still be calling it fatty change grade 1. This is where liver fat quantification using ultrasound has become very, very important, where now we can actually give a number and show that from 30 it has become 20, and that is what galvanizes the patient and the referring physician to continue to do what they are doing. And so it's very important to have this number, and this is the change that is coming. I even tell our physicians, our gastroenterologists, and those who do health checks that liver fat quantification has to come into health checks as a routine, because it is important to know how much fat there is and how much difference your treatment is making in it. Again, to me, the method where we can actually see the ROI, see where we are placing it, exclude the gallbladder, the colon, the blood vessel, is very important as compared to a blind one where we actually hope that we are getting readings from the liver. And then I would say that over the years, technology has evolved, it has become better, and it now, from the E9 which we had to the E10 which we have several machines, in the last, I think, 3 months, we have got the new GE TOTUS, total ultrasound, which not only does, it's the logic TOTUS as they call it, but it also does, apart from great radiology work, it gives you a liver fat quantification, it gives you fibrosis, and it also does great 3D, 4D work, something which actually I'd been after GE to do that. Why should we need to buy 2 machines to be able to do? There are many centers which want only one ultrasound machine to be able to do everything, do the OBS work, do the gynae work, do the routine ultrasound, as well as do shear wave elastography, be able to do liver fat quantification, fibrosis, and so TOTUS, as the name itself says, is total ultrasound. And this machine we've been very happy with. I have no hesitation in saying, and it also has inbuilt a lot of features of artificial intelligence, which will help us in doing a much better job and much quicker. So in conclusion, I'll say that the liver offers a window to health of various parts of the body. We should use it. We do ultrasound of the whole abdomen in day-to-day clinical work, in day-to-day health checks. We now need to focus also on bringing the liver fat quantification along with liver fibrosis assessment into routine health checks, because if, as we see in Delhi, 65% of those who undergo ultrasound have some degree of fatty liver, then there is going to be an epidemic of fibrosis and cirrhosis in the years to come, and we need to actually catch it early and then try to reverse it, whether with lifestyle change, with medication, with whatever may be necessary. And also at the same time, this being a reflection of what is happening in other parts of the body, be it the coronary arteries, be it the carotid arteries, be it the kidneys or other parts of the body, we need to be aware, and such people need to be brought under a regime so that you have not only a long lifespan, but also a long health span, the new buzzword that has come into use. I really look forward to hearing Dr. Sachdev, who is a proponent of this and has been one of the preeminent teachers of how to assess liver health and especially liver fat. Thank you very much, Goldie. Thank you very much, G, for this opportunity. Thank you.
Thank you very much, sir. I think that was a fantastic presentation. In fact, you brought on a very good point. In fact, before that, I would say like 40 years of experience, and who else can better guide us the way it has to be, how the different modalities are working towards better liver health. And you also brought up very good, nicely the stats around 65% children in schools, they are having obesity and they are finding like early liver disease. So that's really alarming. And
this was very alarming. These two studies, both within the schools as well as of the adult population, have been done by, very fine researchers from the All India Institute. Professor Shalimar is there. Professor Nikhil Tandon is there in endocrinology, Professor Shalimar in hepatology, and we have to believe these numbers. And if this is the case with Delhi, I give or take a little few percent, that would be the case with any city of our country. And so it's very, very, it's cause to take charge and do something about it.
Exactly, sir. And what better can be the day like World Liver Day when we are talking about this, because this is about a disease burden which we are looking, and for our future generations, how this is important for early diagnosis, which can help all the doctors to take corrective action at the start. So you really brought up a very nice point around how we were talking about subjective way of like grade 1, grade 2 fatty liver, and then we moved on to an objective way by having newer technologies where we are able to quantify the fat. So thank you very much, sir, for your presentation. And now I would like to invite Dr. Rahul Sachdeva. Dr. Rahul is the director and chief radiologist at BR Diagnostics in New Delhi. And he has published, he has a lot of publications around that, and he has done publications on breast ultrasound and contributed to a number of chapters in various radiology books. He's an eminent teaching faculty at a national and international radiology conferences. He has also held various positions as the national president of Indian Federation of Ultrasound and as the counselor of Asian Federation of Ultrasound. So I would like to welcome Dr. Rahul Sachdeva to please guide us on what you have to say on this World Liver Day, sir. Over to you, sir.
Absolutely. Right. So can my screen be seen?
Yes, sir, we can see.
Great. Welcome, delegates. A big thank you to Dr. Rijo and Dr. Mahajan. They have covered a lot of things which were very, very important. And we can now get down to business and understand the technology, which we really need to know on how to use it and what exactly is expected out of us. Now, just briefly running through what they have tried to come across to you is that you have a liver. If it has more than 5% fat, you start talking of steatosis or fatty liver. Once it goes beyond that, there is a condition which we call as NASH, which is non-alcoholic steatohepatitis. So steatohepatitis is the key word out here, which is the malignant form of steatosis, which we need to be very careful about. And this would then progress to scar tissues and fibrosis, which would further go down to cirrhosis, and then, of course, ultimately end into hepatocellular carcinomas. Now, Dr. Mahajan has just shared with us that Delhi, as always, we are at the top. So Trivandrum is 50% fatty liver, Chennai is 32, Mumbai is 16, we are at 64%. So I think our Patiala pegs are more to be blamed for that, and of course our Chola Baturas. Now, going forward, if you look at this, what they have again and again spoken to us about is that when you talk of the metabolic associated steatoliver disease, so what is this metabolic associated? You have an obese patient who has hypertension, who has diabetes, who has dyslipidemia. So every time you're looking at a steatotic liver disease, you're looking at a fatty liver. In fact, you're looking at all these things together. And that is just one of the signs, I would say, which you pick up an ultrasound, something akin to PCOD. So when you pick up PCOD, you know it's an endocrine problem. Hence, who treats this fatty liver? Is it the hepatologist, or is it the cardiologist, or is it the endocrinologist? That again is something which we need to understand, is because a lot of patients being referred now are from cardiologists. Because the cardiologists have understood that the moment we are reporting a fatty liver, that has its cardiovascular implications. The endocrinologists, of course, are hugely into it. Now, this another very important thing is that the first question the patient asks you, is it reversible? Yes, it is reversible. If you look at this patient who has come with a fibroscan report where you're talking of a KP of 39 and you're talking of a CAP score of 356. This was in October 2022 with a 10 kg weight loss. A steatosis third grade has come down to grade 2. A fibrosis third grade has come down to grade 1. So this definitely is a reversible disease. This is what we need to understand. Another thing, and all these statistics which I'm giving you are all published white papers. Another thing which we need to look at is if you look at patients with hepatitis B virus infection who come to us regularly for checkups, and they come every 6 months and definitely annually. Now that antiviral therapy has become much cheaper and available in the country, after 5 years of antiviral therapy, the claim is regression of fibrosis of 91% and regression of cirrhosis to 74%. This is huge. That means 74% of cirrhotics have regressed back to more or less a normal liver. Now, liver biopsy, we have always been talking about it as a gold standard. Why? Because it will tell us all three stages. It will tell us the fatty liver, it will tell us the steatohepatitis, that is, it can detect the inflammation, and of course, it will tell us the fibrosis. Disadvantage, the major disadvantage is that fibrosis is dynamic. It is reversible. That means the patient will have to be investigated again at the end of a quarter or at the end of 2 quarters or annually. So you cannot keep on repeating a biopsy every now and then. It's an interventional procedure. Secondly, we need to understand that the liver, steatotic liver or a fibrotic liver is a heterogeneous disease. Now, because it is heterogeneous, you are going to take a low sample volume or a sample volume from a particular area. So that might not represent the entire liver. As when we do the ultrasound, we can see the fat spared areas in the liver. So we know even that steatosis is heterogeneous. The fibrosis is heterogeneous. So we really need to have a larger volume. All right. Now, as far as the lab parameters are concerned, now, I have 15 minutes to go into this, so I've just taken things which are absolutely essential and which are required for a day-to-day practice. So we have something known as a fibrosis 4 index. And the current standard operating procedure that we follow is that the moment we see a fatty liver on a grayscale and we have a fibrosis 4 index which is more than 1.3, we go ahead with a shear wave elastography. Now, when you say a fibrosis 4 index, it is very simple. You just need an SGOT and SGPT, the platelets. These are the 3 things you need, and the patient's age. This is the formula. And this is very useful to triage patients of MASH, that is metabolic associated steatohepatitis. Steatohepatitis, like I said, is what the gastroenterologists also fear, because that is the malignant part, that is beyond the steatosis, and before the fibrosis. So if it is less than 1.3, there's a low likelihood of MASH. Between 1.3 to 2.6, you are looking at an intermediate risk. And if it's more than 2.6, you are more or less sure that it is MASH. Now, coming down to business out here is that what are the ultrasound multiparametric markers? Like MR, this also is multiparametric now. So we always have the grayscale. Beyond that, we started off with fibrosis and we used shear wave to give us the answers. Now the shear wave works on speed. That is, it measures the speed of the shear wave within the liver. This gives us the elasticity, hence the word elastography. And this ranges between 4 to 19 kPa. Please understand that these units are very important. We need to know and we need to put it in the same units because this is what the clinicians also understand, that we're on the same page. The moment we start talking of NASH, that again can be used, shear wave can be used to give us a dispersion slope, which gives us the viscosity of the liver. And this is between 8 to 20 meters per second per kilohertz. So we need to understand it is the speed divided by the frequency. And when we come to steatosis, which is a completely different technology. So it is not based on shear wave. This is attenuation or backscatter or speed of sound. There are three ways in which you can check the level of fat in the liver. These three methods are used by different vendors. I have been using attenuation. That gives us the amplitude which will reduce as the fat increases. This is in decibel. Although it is sound, please understand this is not an absolute value. So when we talk of decibels, we are talking of the loudness of a sound. So many decibels. It is not an absolute value, it's a relative value. Everything that I'm saying out here, this is one of the most important slides because this is the essence of the entire lecture. We have to understand this. Right now, elastography has many applications. About a week back, G came up with that we need to emphasize upon our sales team that they need to be speaking more about the role of elastography in the prostate, on cancer cervix. We are extensively using it in breast and it is great. It's absolutely fantastic. Livers, of course, tumors, of course, and we are now going to specifically be looking at the liver today. But elastography, by and large, has gone into everything, including musculoskeletal. And of course, it is an integral part of the thyroid evaluation. Now, when we talk of elastography, now understand this flow chart also. You're looking at the speed, like I told you, and there are two ways in which you look at it. Either you have something as a VCTE, which is the vibration controlled transient elastography. This is the fancy name which we need to understand, which is for fibroscan. The probe tip is vibrating at 50 hertz. The second is shear wave elastography, in which we are pushing in focused ultrasound energy into the organ, in our case the liver, which produces the shear waves. Both these technologies, I was just reading again, there was a question for fat, which is better, is fibroscan better, or is, and this is a question which is there all the time because as radiologists, we are not using fibroscan. And as gastroenterologists, in spite of 15 years of us having the elastography running around in our units, still we are fighting for acceptance with the gastroenterologists. So, of course, the reasons are more economic rather than actual technical. The detection of temporal change in liver stiffness, what I'm trying to say, that if there is a 30 to 35% change in the elasticity of the liver, both the technologies will detect it. That means they are at par. All these statistics are published statistics from hepatology journals. So they are at par. Now, as Dr. Mahajan very clearly said, this is just to show you one slide. So fibroscan is not an investigation, it's the name of a machine. So next time you should tell your physician, your endocrinologist to write down that I would like to get my scan done on logic fortis, logic totus, logic P9. So this is as silly as that, calling it fibroscan. It has to be liver elastography. So EcoSense is the company which makes it. Look at this liver. This patient has actually come into us for a so-called fibroscan. Look at this SCC, look at the ascites, look at the portal vein, and can somebody tell me, if I don't have this grayscale image, what am I measuring? We really don't know what we are measuring. A, it is expensive. B, the probe needs to be recalibrated every 6 months, which is not happening. You can check it from any one of the people who are using a machine. Nobody's recalibrated the probes. 3, if the BMI is more than 40, the results are unattainable, primarily because it's blind. And they understood that. So there is another company called Sonic Insights, which makes a machine called Vellacour, which is a Canadian company. And the thing that they push into this is that you can do a B-mode liver visualization. And for the shear wave production, they use an activation pad, the same as which we use in the MR, right? So this, they also understand that this B-mode visualization is essential component of getting your results. And between them, that is the hepatology journals, between them, they have done this study in which they say that the fibroscan and the Vellacour are at the same, and the area under the curve for steatosis and for fibrosis more or less the same, right? And of course, they've used the gold standard as MR, which is, because that is what we all follow. Now, just an interesting fact, Dr. Mahajan just said that, Supersonic Imagine came up in 2011 with the machine, with the first shear wave machine, and this is how it came up. So Supersonic Imagine, the promoter is a guy called Mathew, and he had developed this technology to look at the consistency or the elasticity of the cheese, because this camembert cheese has a thick crust and a thin interior. So they really didn't know on whether the cheese was good to eat or not. So this is from where the thing started off. Now, in shear wave elastography, you have two types. One is point, with which we all started. The point tells us the speed or the velocity in kPa. That means we are measuring this lesion out here. If the velocity is low, it is a soft lesion, and if it is high, it is a hard lesion. What we are understanding out here, that the harder the lesion, the more will be the speed of the shear wave. We progressed to step 2, like sir said, with E9, which was in 2012, where they came up with a 2D shear wave elastography. Now what this does is, this gives you an elastogram also. And the elastogram is made in such a way that you say that if the low one is given a blue color and the hard ones, the high speed ones are given a red color, right? So soft lesion would be blue and a hard lesion would be red. And then once you have that, you start measuring. These are the measurements that you take on that map. So your reproducibility is much better. We need to understand that this elastogram becomes important and helps us in measuring rather than the point shear wave that we have been using, because this patient is going to come back after 6 months and we must have reproducible results. So the technique is extremely important. Now problems, that is the caveat that we have with these machines. If I measure the same patient on the same day with the same machine, I will have a 20% variability. So don't swear and say. That is why when you look at the charts, which I'll be showing you, there is a range. And if I do the same patient on the same day on different systems, there'll be a 50% variation. These are the studies which have been done on various units. Please understand, the shear wave frequency is extremely important. And every vendor is tuning their machine on a certain frequency. That means if I am going to scan the liver with a 3.5 megahertz probe and do an elastogram, and if I take my 9 megahertz probe and scan the same liver, I will not get the same results. So we are extremely frequency dependent. Beyond that, once the reading goes beyond 13 kPa, there's a huge variability between the vendors. So this must be kept in mind. Now let's come down to what we do best, that is scan. So this is the pre-procedure things which we need to be careful about. One is breathing while we are scanning. Second is the patient should be fasting. 6 hours for the gallbladder, 4 hours is good for this scan, but 6 hours is good because we can get a check on both the things. Patients should not have had an alcoholic binge the previous night. There should be no hepatitis because inflammation, cholestasis will change your readings. There should be no right heart failure because you get hepatic vein congestion. You'll be surprised. Scanned a patient in a nursing home who had CCF, scanned the same patient after a week. The results were completely different. So you need to understand that with hepatic vein congestion, your results will be different. Now, acquiring the raw data. So like I said, fasting for 4 to 6 hours, specific position, we put the patient in left lateral with the arm over the head, and this is basic. When we do a pleural tap, what do? We try to increase the intercostal space. And that is precisely what we're doing out here. We are trying to increase the intercostal space so that we can get a good view of the liver. We can't go on the right side because we have cardiac pulsations. Oh, I'm sorry, on the left lobe because we have cardiac pulsations. So you have to stick to the right lobe. Shallow breath hold. And the ROI placement is usually segment 7 and segment 8. But at the end of the day, practically speaking, when you have difficult patients who are very obese, which is the norm, because those sort of patients that come to you, you're looking at a good window where you're going to avoid the portal vein, you're going to avoid the bile ducts, you're going to avoid the rib shadows. And then we take the measurements. Right now, this is something which I have not discussed earlier, but which is a major part of 2D. That is the quality map. This has to be homogeneous. Once this is homogeneous, then we know that we are good to go. Secondly, most of these machines are tuned to a depth of 3 to 4 centimeters. So when you switch on the box, the place where the box is, do not try to take it too near the liver capsule. Do not try to take it too deep because you will not get the correct results. Once you have a homogeneous quality map, then you start measuring. Now, this measurement which I've taken on this red spot, which you can see, is a wrong way of doing it. I've purposely taken this case just to show you. So all measurements should be taken and avoid the areas which are red in color because we know that there is bound to be some sort of error reading out here because of maybe breathing. Or maybe a blood vessel. Although the machine is smart enough, it would usually show you a red circle. So again, like I said, all these things are for reproducibility. Right, now moving on, when we get the readings, we get something which is known as median. Now, this is pure statistics. You have to understand that these are the readings which we have. When you talk about median reading, the median is a mid reading. So between 62 to 81, the average is 71. But the statisticians have made it even more fine, or it's like something like the CPR ratio. We take the MCA and the fetus, we take the umbilical artery, and then we divide the MCA by the umbilical artery. So what we get is a ratio, and then we know that the ratio becomes slightly more accurate or more refined rather than just using the MCA for a fetal hypoxia or just using the umbilical artery for a placental insufficiency. So this is called as the IQ, or the interquartile range. Now, this interquartile range will basically be that they are taking the lower quarter, which is 64, and this quarter, which is 77, subtracting that and getting it. Anyway, the bottom line is you need to understand that the IQR upon median, that ratio should be less than 30%. If your readings are less than 30%, that means your data is stable. That means your data quality is good. That means it is reproducible. This might sound very complicated, but it's very easy. I mean, doing a liver elastography with a cap, as I call it, does not take more than a minute. That's it. It's a scan which takes a minute, and the machines are so good and the software is so good. If you're scanning well, it's a very reproducible result. It's easier than doing a DEXA, believe me. Now, we have the Society of Radiology and Ultrasound guidelines. They have made it very simple. They say just keep adding 4. Up to 5, things are fine. It is normal. There is no fibrosis. The moment you cross 5, you put it as an F1. The moment you cross 9, it's an F2. Add 4, 13. Add 4, 17. That's where it ends. This you please put down in your report. Like GS said, we want a structured report. This is what you must put down in your report because this interpretation is very simple. By and large, if you're getting a value which is less than 9, it is insignificant, very reversible. The moment you get something like 9, and that means an F2, that means you should start thinking more in terms of steatohepatitis also, right? And then when you get something like an F3, that is more than 13, you're almost sure it's a chronic liver disease. And when you're 17 plus, obviously you'll have a cirrhosis and portal hypertension. Right, now moving on to dispersion. Up till now, what we are doing is, with MASH, we say that if we have a grade 3 steatosis, S3, and we have an F2, so it should be MASH. But that's a very indirect way of looking at it. So we made things more simpler, like I've been harping and emphasizing upon frequencies. So what we say is that we have a certain frequency, we generate the shear wave and we measure the speed, and that tells us the elasticity or the fibrosis. Now you start generating that shear wave at different frequencies. Each frequency will have a different speed, like I explained to you earlier. So this is the flow chart and how it moves, and this is the slopes that you form. So here you can see that there are different frequencies which we are using to acquire the data, and these are different speeds. So when you plot the graph, if you get an elasticity of 2 and a viscosity of 0.1, whereas out here you're getting an elasticity of 2 and a viscosity of 0.5. So you can see out here that you get different slopes. So if their liver is abnormal, or if the liver is more viscous, or if the liver has inflammation, or if the liver, as we call it, steatohepatitis, you will definitely get something like this. So we can again quantify. Like Dr. Mahajan said very well, the patient compliance hugely improves. You tell a patient your blood sugar is 120, he comes back after 15 days, now the blood sugar is 110, he knows he's on the right track. If the blood sugar is 125, he knows he's not on the right track. So the moment you start giving figures, the patients are very happy. And this is how you grade the MASH. So you say if it is 11.6, like I said, meters per second would be the speed, kilohertz would be the frequency. If that 11.6, it is mild, we put it as A1, 11.7 is A2, and 16.2 becomes A3. Problem with dispersion is, very obese patients, there is still a problem. If there is advanced fibrosis, again, there is a problem with the results. So these are the caveats which we need to keep in mind. Now, like we said, fatty liver, very rampant, very much there, 64% in Delhi. But as far as our ultrasound community is concerned, in Delhi at least, it is 100%. Everybody is reported 2 things. If it's a female, it's a PCOD. And anybody, if it's a liver ultrasound, it's a fatty liver. That is standard. Now, why does this happen? Now, first of all, 2015, in the MR which I had, we had something called as an ideal IQ, and that was measuring the liver fat. Although nobody ever asked for it, nobody at least paid for it. We used to do it just for our own interest. Now, the MR is a gold standard because of 2 things. Very briefly, it's a direct measure of liver fat content. It directly measures the liver fat. And the reproducibility is excellent because it doesn't change with manufacturers or with a Tesla. So whether you're on a 1.5 Tesla or a 3 Tesla, whether you're with GE or with Siemens or Philips, the readings don't change. So it's a very robust, standardized system. But unfortunately, again, it's just running a sequence like an MRCP. But then ultrasound is what has caught on, and ultrasound is what is required. Now, this is my unit, routine patient walking in. I have labeled this as grade 1, grade 2, grade 3. And as sir said, very, very subjective. That is the limitation. Somebody might call this grade 1. I'm quite sure you all guys can have a look at the picture. Somebody might put this as a grade 3. So it is subjective. So we said, okay, let's refine it. So did this MR, and like we said, above 5% is steatosis. So we look at the fat, which is at 2%, 8%, 14%, 28%. This is as per the MR. Now look at how it looks on ultrasound. So a normal liver, this is how it looks, the kidney looks. This is how the hepatic veins look. This is how the portal vein looks. Now see how it degrades or deteriorates, right? So this improves the specificity because we are looking at it with a different perspective. Then we came up with the hepatocellular index. So what we did is, At the same level, you put two ROIs, and then you see if the liver is, if the ratio of the hepatorenal index is more than 1.2, so you call it a fatty liver. Although again, we are assuming that the that the renal ecogenicity is normal, which again is not true in all cases, right? So to summarize, conventional ultrasound, what are the problems? It is not quantitative, so it's good for detection. It cannot tell you early fibrosis MASH. It gives you great information when you are cirrhotic. So when you have a structural abnormality with surface nodularity, when you have portal hypertension, ascites is good, but for the initial stages, not. And like Dr. Rijo said, that we are all talking of preventive radiology now. We are not talking of diagnostic, we are more into preventive. So attenuation coefficient. Now, what is this? This decreases the, I think I've overstepped my time. This decreases the amplitude, right? So you can see this as the liver is fat, the amplitude decreases, so you see less. Now, this attenuation correlates well with the histopathology, with the MR, with the grayscale grading, but it does not directly measure liver fat, unlike the MR, and we infer the presence through interaction of the ultrasound beam with the tissue. Like I said, relative. Again, problems, measurement, variability. So you can see patients, green, no steatosis, blue with steatosis, different vendors, different values. You can see it out here. Now, acquisition is the same as shear wave, just a few caveats which I use personally. A, I take this box deeper. B, I angle the liver cap at the liver capsule. I do not keep it parallel. If you can see the liver capsule running like this, I've angled it because this reduces the reverberation. So this is where the quality map out here is questionable. It doesn't really mean anything because the measurement works only in a horizontal fashion, doesn't go vertical. So this is red and blue, but doesn't really help. These were just a few things to few practical points. And if you look out here, this is the grading of steatosis, which is again very simple. If you're above 230, you're S1. If you're about 250, you're S2. If you're about 270, you're S3. But believe me, the patient is very happy when we tell him you're 275 and 6 months of no booze and he's at 250, he's thrilled. And that improves the compliance, right? So just to look at the future direction and challenges. See, I've not gone into that controversial thing, but I think I've already taken 25 minutes. Proliferation of tests with no consensus. We have all, the lab, the clinicians, the radiologists, everybody's into it. Reproducibility is thing which we must keep in mind. Reporting, of course, we are reporting everybody has fatty livers now. And needle in a haystack is that the HCCs are not always seen in cirrhotics or fibrotic patients, so we need to be careful about that. And now with AI coming in, they are looking at, taking cinematic sweeps of the liver and sending on the cloud. That's a new thing which is coming up. And inconsistency in the epidemiology. And again, treatment by the cardiologist, the hepatologist, or the endocrinologist, as I mentioned earlier. Right, so these are the final 4 lines. What I'm trying to say out here is that you don't talk, you don't write and tell your students. What you preach is what you should be practicing. Thank you very much.
Thank you, Dr. Rahul, for that wonderful presentations. I can see some couple of questions in chat box. So this is one is coming from what about patient from Dr. Tejasvi? What about patients with ascites?
Yeah, like I showed, because if you are asking me, there's no problem. Even with ascites, you can get a good window because you have a good grayscale with you. So if you have a good window, you can acquire very easily.
Okay. There's one more question from Dr. Chandramoli M. If the patient is having renal disease, how do we interpret?
I already mentioned that. With renal disease, the problem is that we are stuck because normally when we talk of fatty liver, we are talking in relation to the kidney. Right? So then, of course, we'll look at other parameters like the portal vein, the hepatic veins, if we don't have attenuation with us.
Right. Good. I think meanwhile, I would request all the delegates to please post your queries, questions on the chat box. Meanwhile, I'll give some time. So I would request Hardik to just play the video because we talked about the technology and we have the recent introduction, which Sir also mentioned about logic totus. So maybe Hardik, till the time our delegates pose their questions, can you just play the video for Logic Lotus?
Oh, sir, just let me know if the audio is there.
Yes.
Hey Logic.
Okay. So meanwhile, I think since we gave some time to delegates to pose questions, we have a few more questions coming in from delegates. So one is from Dr. Pradosh Kumar Sarangi. Does the fibrosis score vary vendor-wise? Yes, the values vary vendor-wise. Where can we read more about liver elasto and its recent updates?
It's all over, sir. It's all on the net. Today, everything is available. Aunt Mini, Radiology, Journal. RSN is the best place.
There's one more query. Yes, Dr. Riju. Even normally the liver is hyperechoic to the kidney. So when do we call a liver as grade 1 fatty? They are set parameters.
Normally, it should not be hyperechoic. When you look at a liver and the kidney, it should be isoechoic. There's no reason for the liver. The moment the liver is hyperechoic to the kidney, it's a fatty liver.
See,
What do you feel, Joe?
Yeah, Dr. Rahul, one of the major doubts for most of the practitioners is fibroscan gives the CAP score and the liver stiffness value. And we are now in a position to, the ultrasound machines can now in a position to give the liver fat quantification and can give, but we have still not highlighted the potential of ultrasound in evaluating early chronic liver markers, early chronic liver disease markers. You can assess for the target organ damage in terms of with the color Doppler, with surface nodularity. So this evaluation of portal hypertension, a comprehensive evaluation is something that the radiologist should be focusing more. And this part, it is essential for us to give a complete evaluation of the liver with fat quantification, liver tissue stiffness quantification, and the 2D ultrasound evaluation of the liver for, and with along with color Doppler and high resolution ultrasound for any changes, early changes of chronic liver disease. So that can give a larger perspective, larger dimension to the whole thing, and can act as a something that it is time. The problem is radiologists are 30,000 in number and gastroenterologists are 4,000 plus. So it is time for all this 30,000 and 4,000 to act together, because the epidemic is so alarming. So the burden is too big that even the 35,000 people are not enough to handle it. So let us work together. Let us quantify it. Let us give a comprehensive evaluation, make these people aware, make the patients aware about the risk they are going through. Currently, most of the people are, it's still being recorded that most of the people do not know whether they have got a fatty liver disease. And even if it is there, the significance or the risk stratification of that in terms of the possibility of having a chronic liver disease, and also the possibility of having a cardiovascular disease or other non-communicable disease. So that's a larger issue that has to be addressed, and the radiologist has to transform their practice. Just Dr. Rahul, as Dr. Rahul rightly said, it is time for us to transform our practice to give a comprehensive liver assessment with liver fat quantification, liver tissue stiffness elastography, and the 2D and color Doppler evaluation of liver in the portohepatic system. So, Rahul, wonderful lecture you have given, and it is.
There's one more question which has come, sir. Does the patient position, lateral or supine position, make a difference for elastography?
Yeah, like I said, it's basically to get a good window. If the patient is supine, you really cannot get a good window because you need to avoid the vessels, you need to avoid the bile ducts. You need just the liver parenchyma. So that's the whole idea.
Great. I think that's fantastic, sir. I understand. So thank you very much, Dr. Rahul, for this fantastic presentation. And on the final note, I would request Anup Kumar, our business head for ultrasound, for closing remarks. Yes, Anup.
Hi, Anup.
Hi, Anup.
Good evening, everybody. Thank you so much. Wonderful, wonderful webinar. Thank you so much, Dr. Richard, Dr. Mahajan, Dr. Rahul. Such a wonderful talk. This is such an eye opener, right? 20 years, I think all of us take scans. All of us have been seeing fatty liver in our reports. We didn't know what to do with it. And today with, UGAP coming in today, putting a quantified value to it, it's opened up a lot of eyes for a lot of us, even in the GE family. Why we chose this is suddenly we realized that, if we are in this business, we might as well do whatever we are supposed to do. So we said, can we go and do something different? Yes, it is going to benefit GE, but, it can definitely benefit a lot of people in the 35 plus current lifestyle being bad. The minute I know a UGAP score, each time I eat something or drink something, I'm taking a look at my report and taking a look and wondering the next time I take a scan, what's the number going to be? So I think it's wonderful. Thank you so much for taking time off on a evening like this. Thank you, Goldie and team, for setting this up as well. Thank you to all the delegates who stayed on and shared this wonderful webinar with us. Thank you so much. You guys have a very, very good evening, and happy Easter Sunday to all as well.
Thank you. Thank you.
Thank you. Happy Easter to you too.
Thank you, everyone.
Thanks. Bye.
Thank you, sir.
Bye,
Thank you very much.
Bye, Goldie.
Bye.
Bye, Anup.
Good day to you. Thank you so much. Take care. Bye.